Hello and welcome to this month's episode of the Atrium. This month we're going to be tackling proximal coronary anastomosis with Dr. John Puskas. Welcome everyone back to another episode of the Atrium. We've got a fantastic guest with a great topic that is so important to all early stage trainees. This is something that you need to get right if you're going to get your coronary surgery right. So welcome to the episode, Dr. Puskas.
Thank you. I'm glad to be here.
Thank you so much. So I always like to start with just a bit of a background to my guests so that our listeners know that who we've got on has the right credentials to be talking about this subject. And I think there's no better person we could really get on for this. You are currently Professor of Cardiothoracic Surgery at Emory University and Chief of Cardiothoracic Surgery at Emory University Hospital in Atlanta, Georgia. You are internationally recognised in coronary revascularization, co-editor of the first textbook devoted solely to this topic, and co-founder of the International Coronary Congress. So another, again, a congress dedicated to this topic. And I think that's really worth recognising because sometimes revascularization can just be sort of seen as the bread and butter of cardiac surgery, and it's, it doesn't get its own spotlight, but it is the bread and butter, and we should be really trying to do the best we can. Thank you so much for coming on. It is a real pleasure. And there's many other credentials I could go through, but yeah, thank you. I just want to ask, how did you find your love for sort of the topic of revascularization?
Well, Alice, coronary artery disease is the number one killer of human beings. As surgeons, we have coronary artery bypass to wield against that greatest of all enemies. So I decided to focus on that. Use my surgical intuition and innovation and technical expertise to focus my energies against the greatest threat, most common natural cause of death, especially in the Western world. So it seemed logical and natural to do that to me. I also find the operation endlessly fascinating, the meticulous nature of the coronary anastomoses, the patient particular an individualized choice about conduits and graft configuration, the really demonstrable benefit that patients receive. We most commonly completely relieve their angina and greatly reduce the risk of later spontaneous myocardial infarction and cardiac death. So the operation is extremely effective. It's technically challenging. It continues to evolve and improve. And so it's really, to me, a very captivating way to spend my professional career.
It's really nice to hear, and it's interesting because actually coronary surgery and the meticulous nature, like you mentioned, is one of the reasons I went into cardiac surgery, is that preciseness and how much care you have to take. I really like it. And what I really like about, your career is that you've now sort of at the forefront of going into all these total arterial grafting and looking at things such as hybrid, working with the cardiology colleagues. So I think that's all really interesting, and maybe we'll sort of touch on a bit of that at the end. So I thought I'd start the episode by talking about a bit of background to, we're talking about proximal anastomosis at this point, and we'll cover distal anastomosis in another episode in the future, hopefully. Sort of the background is that we've been doing proximal anastomosis since we started doing grafting, when René Favallaro in the 60s, saphenous venous graft to the aorta. And our technique hasn't changed per se, the basics of the technique hasn't changed, but sort of our understanding of where and how to do it, new devices and new techniques to minimize the risk to our patients of embolic risk, but also to increase our long-term graft patency has changed. And then we sort of into the 80s and 90s, we started thinking about a Y and T graft or no-touch aortic techniques. What would you say are the sort of key milestones for proximal anastomosis in its timeline?
Well, as you point out, Alice, the original bypass grafts by René Favallaro at the Cleveland Clinic were, in fact, aorto-coronary saphenous vein grafts. It's actually true that the very first coronary bypass operation was probably done in the Soviet Union by a man named Kolosov, and he actually used an internal mammary artery graft, interestingly. Since the very beginning of coronary surgery, as it has been popularized, the aorto-coronary bypass graft has been the mainstay. And still today, the most common coronary revascularization performed is a single ITA to the LAD, and then 2 or 3 bypass grafts in the form of reverse saphenous veins from the aorta to distal coronary targets. So it remains from the very beginning the most common coronary anastomosis and a fixture to how we perform conventional bypass. It has evolved in terms of our understanding of the risk of embolic disease from the aorta. The original operation was a cross clamp for the distal anastomoses and then partial occlusion clamp for proximal anastomoses, so 2 clamps on the aorta. That carried with it a 2 to 3% stroke risk. I think we've very clearly understood that a single clamp for on-pump bypass surgery is better and reduces the risk of neurocognitive and stroke adverse outcomes. So we most commonly now perform proximal anastomoses when we do those with veins on the ascending aorta under a single application of a cross clamp. How we punch the aorta to create an aortotomy and how we suture the vein to it actually is remarkably individual. The surgeons do it all sorts of different ways. They all seem to work. Amazingly enough, we have no controlled trials related to technique for proximal anastomotic construction. It seems to have been considered since the beginning, an afterthought, really. The distal anastomosis was the great focus because it's technically more demanding. The margin for error in sutures is 1/10 of a millimeter instead of a millimeter as it may be on the ascending aorta. But it's important to remember that the blood must flow through both anastomoses to nourish the myocardium. And so I think it's really important to do proximal anastomoses as precisely and as perfectly as one possibly can.
Thank you so much. And actually, you were part of the team that put together this 10 commandments for proximal anastomosis that was published last year. We'll kind of cover each of these commandments actually as we go through, but I thought I would just touch on it now at the beginning just so that people can go off and read this paper in detail, but just cover what they are. And so one of them, if we start from the beginning, is preoperative assessment of the ascending aorta. And number 2, intraoperative epiaortic ultrasound. Number 3 would be considering anaortic revascularization strategies. And number 4 is avoiding an aortic side clamp, as we've just talked about. 5 is piggybacking proximal anastomosis. And 6 is alternative sites for those proximal anastomosis. And we sort of will maybe touch on that a bit later. 7, test your graft, which is, something that I think is really important. 8, measure twice, cut once. 9 is radio markers on each anastomosis. And 10 is integrate all the possible techniques. So I just kind of, I think this is a nice guide that is maybe a step above the level for sort of our audience, but it's really worth them going and having a look because it's showing how our understanding of proximal anastomosis and is developing and what the future is, because lots of these techniques not all centres are using. What made you put together this paper?
Well, this paper again addresses something that has been largely relegated to the commonplace commodity that gets little attention. But if you actually look at how different surgeons perform proximal anastomoses, they actually all do it rather differently. Clearly, it is possible to construct a saphenous vein anastomosis to the ascending aorta in multiple different ways. Whether one is better than the other, of course, is a judgment issue at this point, absent any randomized data. But we thought that at least it should be discussed, that at least we should focus some attention on it and at least share some of our own thoughts about it. Gianluca Torregrossa is a coronary specialist at Mainline Health in Philadelphia at the Lankenau Medical Center, and he was previously my coronary fellow when we both worked at Mount Sinai, Morningside Hospital in New York. So he had the impetus to do this. We worked on it together, and his fellow, Dr. Baudo, helped with the manuscript. But these ideas, I think, of merit and benefit to every surgeon doing coronary surgery. It's worth thinking about what you're doing and how you're doing it. And ask yourself at least, can I do it better? Is there a better way? Is there a safer way for the patient? Or am I just doing it the way my professor did it? And that professor did it because that was the way his or her professor did it. I think we need to recognize, as you pointed out earlier, that it was the 1960s when this anastomosis was first constructed. Very few things that we do or operate or utilize these days are unchanged since the 1960s. There's no car, no radio, no telephone, no television. No other technology in the operating room really has unchanged since the 1960s. We should at least examine what we're doing as a routine and ask ourselves whether it can be improved. Just because we've done it the same way for a long time doesn't mean we've been doing it the best possible way.
I think that's really nice thought for our residents and trainees to take sort of in all aspects of their career, is have that inquisitive mind of, can I do something better for my patient? We'll get into sort of more the nitty gritty about the technique of proximal anastomosis and the background and when we do it and things like that. As we've discussed, most commonly it's when we are grafting a saphenous vein graft. We've done our distal onto the coronary target, and now we're going to do our proximal end onto the aorta. The other times it might be used would be if we were doing sort of free arterial grafts, a radial artery graft, or a free internal mammary graft. And sometimes even the gastroepiploic artery can be used, and that would be, again, we need a top end and a bottom end. Now, does the type of graft alter the technique?
I think that's an important question. When I do vein grafts on the ascending aorta, which is very uncommonly, I think very carefully about the orientation of the graft. I choose the punch size based on the size of the graft. We interrogate the aorta with epiaortic ultrasound to identify the least dangerous point or place on the ascending aorta to construct the graft. And I think very importantly, we orient the graft to optimize its geometry and its pathway from the ascending aorta in a gentle curve to the distal coronary target without kinks or twists. Do we do it differently for a vein versus an artery? Well, I will say fundamentally no. Fundamentally, the suture placement is identical and it has to obey the same basic rules. But the suture placement must be more meticulous with an arterial conduit. The hole typically is smaller, or the aortotomy is smaller, and the sutures are finer. We have to recognize that a vein is an extremely accommodating and convenient tissue to use in sewing to the ascending aorta. It molds and conforms and rarely leaks. It's also very strong and holds sutures very nicely. Arterial conduits are not as compliant, not as big, not as thick-walled, and in some ways not quite as strong at tolerating tensile force as well as a vein does. So one must be more meticulous with the arterial conduits. I personally don't like sewing arterial grafts directly to the ascending aorta unless it's a large arterial graft, typically a radial artery, and a relatively thin-walled aorta. I think it's very hazardous to sew, for instance, a small or medium-sized internal mammary graft to a thick-walled aorta. That is an anastomosis that at very best is technically difficult to do and is likely to leave a good deal of aortic media exposed. If bleeding develops, it's hard to repair that bleeding with complete certainty that the graft has not been compromised in any way. And in those scenarios, I would much prefer to sew a small hood of saphenous vein directly to the aorta and then place the arterial graft on that hood, sewing artery graft to vein hood rather than sewing artery graft directly to the aorta.
Interesting, really interesting, and nice tips there. So in principle, no, but there are some aspects that you need to acknowledge when using an arterial graft on the aorta. And then you've kind of just touched on it there, talking about when you are anastomosing onto the aorta, and one of those is site selection. And it's one of the most critical decisions that we have when we come to performing our proximal anastomosis. Although it kind of, maybe as a resident in surgery, it seems often quite obvious to the main surgeon, the lead surgeon. To a trainee, you need to understand that they've had many experience and they know where they're going. And ideally, it's on the anterior or the right lateral wall of the ascending aorta, between the sinotubular junction and the origin of the brachiocephalic artery. And you really need to avoid areas of calcification or heavy atheroma. And traditionally, people would just palpate the aorta, have a feel, nope, this is fine, let's go for it here. But we're realizing that, that's not always the best technique, and we can miss things that way. And so people are much more using things like, you mentioned epiaortic ultrasound, and that's the gold standard, and CT assessment. And this is especially important in our high-risk patients, such as those with end-stage renal disease or smokers or insulin-dependent diabetes, because it helps reduce that stroke risk by making sure we're not going into a calcified area. What would you say is the most important thing with regards to site selection on the aorta?
Well, we want to choose a site that is easily accessible for the surgeon so that a perfect anastomosis can be created. We want that site to be such that the conduit can reach without tension or kinking to its designated target on the heart. We'd like to have a site that does not have a high likelihood of stirring up or dislodging calcified or atherosclerotic emboli from the aorta itself during the punching of the aorta or the anastomotic construction itself. So multiple features are important. The epiaortic ultrasound is a key tool to use for this. Frankly, whenever we put a patient on the heart-lung machine, that means cannulating the aorta and clamping it for cardioplegic arrest, or do proximal anastomosis, we always perform an epiaortic ultrasound. It has been demonstrated time and time again that the surgeon's fingers are not adequate to interrogate the interior of the ascending aorta. You simply will miss things that are not palpable but can be embolized. So we don't rely on digital palpation. Instead, we make a quick ultrasound scanning of the aorta. And once the surgical team is used to that, we pass this sterile plastic sheath over the drapes to the anesthesiologist. They put the probe in it. We retrieve it sterilely, place that on the aorta, and make our images. It's literally 30 to 90 seconds total that it takes to do a thorough evaluation of the ascending aorta. And that allows us to choose exactly the right spot. And then we mark it with a marking pen. We're going to put one here. We're going to put one there. And then we know that when we choose that site, in my case, when I do a proximal anastomosis, it's almost always with a heartstring anastomotic device, a clampless device. But we know exactly where we're going to deploy that.
Nice. So those main points is so you can perform the anastomosis safely and correctly to the best of your abilities, so that the graft isn't kinked, and so you avoid this calcification. And actually, those 30 to 90 seconds using an ultrasound can make the difference of a embolic event to the patient. And it's something that we should be just taking that 30 seconds to do.
Absolutely. Now, there's one other aspect to the choice, and that is that you have to remember, if you're doing this on a clamped arrested heart, the right ventricular outflow tract is empty. It will not be empty when you come off bypass. It will be bigger and fuller and firm. And if you place the proximal anastomosis too proximal on the ascending aorta, the full right ventricular outflow tract can bend or kink those grafts. So it's important to avoid placing proximal anastomosis too low and near the right ventricular outflow tract. That's an error that is hard to recover from without redoing the anastomosis. Similarly, the pulmonary artery itself, you should look at the pulmonary artery when you open the pericardium and look at the right ventricular outflow tract and make a mental image of that in your mind, so that when it comes time to doing the proximal anastomosis much later in the case, you don't put them so much towards the left side that the full pulmonary artery will kink them, and not so low close to the aortic valve that the full right ventricular outflow tract won't kink them. Also, orient the graft so that it passes in the direction that you want it to go without having to make a bend or turn, especially not a bend or turn adjacent to a full pulmonary artery or right ventricular outflow tract. This is a prescription for a kinked and therefore closed graft.
I think, we'll talk a bit about sort of the root of the graft shortly, but I think that's something that many people won't appreciate. We do things like, filling the heart, so we can check the size of the heart, but sometimes, that won't fill the pulmonary artery, and therefore you'll miss that part. So it's a really nice idea to keep a mental image of it. As we move on to thinking about our step-by-step of performing this, so we've prepared our aorta, we've cleared off our adventitial fat, and we're going to prepare the graft. So as we were just mentioning, we want to check the length, including with the heart field and including that mental image of our right ventricular outflow tract. We want to cut the graft to the conduit to the appropriate length, remembering no tension, no kinking. And quite often people will put a bulldog to prevent air entry into that graft and obviously down to the coronary artery. As we discussed, this can be done under cardioplegic arrest or with a partial occlusion clamp. Traditionally, it was more the occlusion clamp, and we're leaning more towards, just as we mentioned, this one time of clamping. Actually, where we use the cardioplegia, that hole is often used as a anastomosis point as well, because you've got a small hole already in the aorta. So we would clear off all that fat, and then you're going to make an arteriotomy with a small incision with a clamp segment of aorta. And then you'd use your punch, as we've mentioned. These come in a variety of sizes depending on the size of your conduit, and it creates a clean circular opening. And one thing to mention is actually it's going to take out a chunk of aorta and make sure you know where that part has gone, and it's not going to fly off and occlude an artery somewhere. And making sure that that punch size matches the graft diameter to prevent mismatch. So this is like the preparation, the arteriotomy. What are the key points of that residents should remember?
You want to prepare the chosen site on the ascending aorta so that the punch will not become entangled or obstructed by epi-aortic or peri-aortic fat. That's the only purpose for trimming off that fat, is to make a clean anastomosis, including the punch, which has to be clean. So we generally will clean that off with a pair of Metzenbaum scissors and then use careful cautery to guarantee hemostasis around that before we go on with creating the proximal anastomotic sites and subsequently sewing the anastomoses onto those sites. You mentioned being sure to avoid embolism of bits and pieces of the aorta from the punch itself. I think that the punches generally do indeed capture the portion of aorta that they cut, but then you have to clean them before reusing them. So the punch needs to be cleaned thoroughly before you reinsert it in the aortotomy to punch that hole a second or third or fourth time, as you may do, to trim the edges, make it uniform, make it a little larger than it was, to optimize it or customize it for your coronary conduit of choice.
Great. Sort of more onto the nitty-gritty of actually how do we sew this onto the aorta. And I think that's something that as a trainee, as a resident, you watch and it appears very simple, and then you get the opportunity to do it, and suddenly you're tangled up and you're back to front, and all your angles are wrong and everything. We're going to use a continuous polypropylene suture. 6-0 or 7-0 is typically used. We will sew on the heel of the graft first, typically anchoring it at the downstream edge of the aortic hole. Some people put 3 or commonly put 5 stitches along that heel, and the orientation of where you're placing it will depend on the side. And if you're coming on the left, traditionally onto the graft, it would be clockwise, sort of around the heel, and counterclockwise around the aorta. And if it's on the right, it would be counterclockwise around the heel and clockwise around the aorta. And it's quite difficult to imagine, but it's something to try and get in your head. And the sutures then run around both sides and finishing at the toe. And we need to think about the fact that often our graft is more of an oval shape, whereas the hole into the aorta is a circular shape. So that will depend on the size of stitches you place on each of the items, the pieces. Some of the bits to avoid is purstring the aorta or narrowing that graft lumen, because you want to ensure there's a good lumen for good blood flow. You want your evenly spaced stitch. And you want to take about 3 to 5 millimeters of the aorta, and it will obviously be less of the arterial graft. When we think about the orientation of this graft onto the aorta, it will come off at a gentle angle of sort of 30 degrees without any torsion or tension or kinking. And the reason that's the angle is that will avoid turbulent flow or impaired flow. And then it will need to be de-aired before flow is restored to prevent an air embolus travelling down into the coronaries. So there's quite a lot to cover. And I know that's it's a lot to imagine and picture. What would you say is the key point when we are talking about where we place our stitches to connect the graft to the aorta? And how would you say to trainees to begin doing this?
Well, Alice, you've made many good points, and they're all correct. I don't think that there's just one way to sew this on to the aorta. I think that there should be one way that you use all the time and you're really good at doing. You shouldn't make it up or vary it. I really do believe in standardization. That's how we reach reproducible excellence. It's important to also note that the orientation of the conduit on the aorta is very, very important, and it is completely determined by your placement of the first stitch. Once you've placed the first stitch through the conduit and through the aorta, the orientation of the graft is determined. So think about it before you put that first stitch in. Exactly how do you want that the heel of that graft to be oriented? I typically put 2 away from the 2 stitches from the heel, then 2 more, and then parachute it down with those 5 stitches. So I'm asking myself, okay, this is 2 stitches from the heel. The heel has been spatulated, so we have a clear indication of where that heel will be. Where do I want that to be so that it cannot be kinked when the pulmonary artery and right ventricular outflow tract are full? And it will have an unobstructed, clear, and gentle curvature towards its target. The other thing I want to comment on is just to add to what you said previously. You mentioned that the conduit, once it is spatulated, is oval or oval-like. But the hole that we've created in the aorta is circular, or we're trying to make it circular. And you present that as if that's a bit of an issue. It is an issue, but it's a good thing, and there's a reason for that. We want the hood of that anastomosis to be like a cobra's head or cat's paw, to have some height. And if you take an oval and you place all the sutures at angular intervals around that, equivalent to the angular intervals of a circle, then you're sewing the oval to the circle in a way that will create a vertical height on the oval. So the interval, the gap or space between the sutures is not a distance. It's an angular distance that you're thinking of in your head when you're passing that stitch. I'm going to cover 1/20th of the circumference or 1/15th of the circumference of this anastomosis with each suture. And that's an angular measure. At the end of the day, the oval and the circle both have 360 degrees. But you want to place the suture so that it is always perpendicular to the circumference or edge of both the conduit and the aorta as it's passed. And that will mean then that they're evenly spaced, they're equal in length, the gap between them is identical from an angular point of view, and at the end the anastomosis will sit up high and not be flattened. And this is a really important concept. The graft must have a hood. It should look like a cat's paw, not like a drum. It shouldn't look like a goat skin pulled across a drum. It should not be flattened or taut. It should be large, tall, and capacious. And the reason is because the outflow, imagine my wrist is the outflow. The outflow depends that this be a tall anastomosis. If it's a very flat anastomosis, how will the blood get in to this outflow tract? It'll be a slit-like exit from this anastomosis, and we want it to be circular, equal to the diameter of the conduit itself. That requires that there be height equal to the diameter of the graft at the outflow point from the graft. All this sounds very technical, but it's actually very, very simple. It's often ignored, and that's how we get grafts closing very early. A small conduit sewn without a great deal of spatulation to a large hole in the aorta will be flattened. And then it typically has a lot of tension on it. It may leak. You put a few more stitches in to make it hemostatic, and that makes it even more flattened. And now all you've done is created a hole in the aorta and patched it with a vein. You haven't anastomosed a graft to it because there's no outflow from that graft. It's a slit. And that graft will be closed before the patient's out of the intensive care unit, maybe before they're out of the operating room.
Yeah. So I think that's a really key point to remember. And, you know, for our trainees getting their heads around suturing graft onto the aorta, we talk about in to out and out to in. How do we tackle this when we're sewing onto the aorta?
Well, it's a really good point. I do not like to make horizontal mattress stitches. Some people do place a mattress stitch in the heel, pull it down. I like to have mine over and over, which means that I begin on the right-hand side of my right-hand side of the conduit, 2 stitches from the heel, coming out to in on the conduit and then in to out on the aorta, and running it from that point all the way around to the toe. That means that the last portion, which is connecting that first stitch to the toe, those stitches will be placed in to out on the graft and out to in on the aorta. There's nothing inherently wrong about in to out or out to in. What matters are the following concepts that must be considered sacrosanct. First, each stitch, and I mean every stitch, must include all the layers of the conduit and all the layers of the aorta. That sounds simple, but it's actually an important point, and it's not always easy to achieve. The reason you hear occasionally of a patient developing an ascending aortic dissection early after coronary bypass operation is almost always because of a problem with the cannulation site, or I believe commonly, sutures on the proximal anastomosis which do not include all the layers of the aorta, therefore opening up the opportunity for dissection to occur at the proximal anastomotic site. So every stitch must pass through all layers of the aorta and the coronary conduit, without exception, every time. We want to achieve that without traumatizing the intima of either the aorta or the graft. With those 2 important caveats, it doesn't really matter how you place the sutures if you can achieve those goals. But pick a way that you're comfortable doing it and do it the same way every time. That way you and your assistant and your scrub tech and everyone in the room will know what's coming next.
I think that's great. And I think that's something that, I've heard from multiple people I've had on this podcast is pick a way and just do it well. Just get good at what you can do. So it's nice to hear you echoing that as well. And, for example, just so residents can picture it in their head, say you were grafting a saphenous vein conduit onto OM1. How would you orientate your proximal anastomosis on the aorta?
Again, I think it's most important to try to make these very direct. And when I direct, I mean so that there's no turn or kink at the proximal anastomotic site in any plane, that it's anterior enough on the ascending aorta that when it comes off, it doesn't have to go up over the pulmonary artery. And the graft is oriented such that it may be a little bit towards the head and then curve gently around the pulmonary artery to come over to the OM1.
Where would you place your heel suture for, say, that proximal anastomosis?
It is placed so that the graft is oriented upwards, not typically straight off the aorta, but a little bit towards the head, maybe 30 degrees towards the head.
That's just an example. I think experience will help residents picture this in their head. We've talked about, the basics of it. And like we said, there are many people have different techniques. And so I thought I'd just touch on that a bit about sort of the variations and the alternatives. So as we mentioned, we know now that clamping the aorta comes with its inherent risks. People are sort of talking about anaortic cabbage, which is avoiding the aorta entirely by using only in situ or composite grafts. And I know that, that's something that you're a big proponent of. Or clampless devices. That will allow inflow without clamping. They're not as commonly used. The other way we can avoid, we talk about is sequential grafting. So one vein graft could supply sort of multiple coronary targets by piggybacking, or we can also sort of piggyback onto your lemur using Y or T grafts, using the radial onto the lemur. And that again will avoid your aorta. And sort of things like aortic stabilizers in elf pump surgery and anastomotic devices. You mentioned earlier, you always would use a heart string. There's other things called enclothes or the viola. So at a very basic level for our residents, if we think more about these sort of devices that allow us sort of more clampless techniques, what would you say are the key parts?
The benefit of the clampless devices is that you can construct an anastomosis on the ascending aorta without a clamp. That can be done on pump with no cross clamp, or it can be done off pump entirely. The three devices you mentioned, the viola, the enclose, and the heartstring all work. The heartstring's been around a long time, and I began using it a long time ago, and I'm very comfortable with it. The Navarre enclosed device allows the creation of more than one proximal anastomotic site with a single device, so it's economical. It does create one additional small hole to insert its special device, but it certainly works. The viola is newer on the market and is showing real promise. I think that for the average person listening to this podcast, they're going to be a fellow or resident in a program where on-pump surgery is the norm. And so you're going to be performing your proximals on the heart-lung machine on an arrested heart. And I would just simply encourage that be done with epi-aortic ultrasound to guide placement of the cannula and to guide the location for the application of a single cross clamp, and to do the proximals under that single cross clamp. That, I think, is the key to minimizing neuroembolic consequences from a traditional on-pump clamped operation. We can talk about the no aortic touch off-pump option, at another date or later on this podcast. But that's a very advanced and different operation from what most of the trainees will be exposed to.
Yeah, I think it's just a flavor so that people understand that there are other ways and things. And with anything, there are pitfalls and complications. And we really need to be thinking about those when we're doing our surgery to minimize our doing this. As we've spoke about multiple times, your atheroembolism and stroke risk is a big complication of a proximal anastomosis. We've also talked about technical failure, whether that's too tight sutures, the poor angle or size mismatch, kinking, and other things such as competitive flow. So if the native coronary only has moderate stenosis, the graft may not flow well, leading to stasis and occlusion. And this is something we have to think about with both our distal and our proximal anastomosis. And there's now devices that intraoperatively, as seen in the pictures shown, intraoperatively can assess flow in the grafts. Is this something that you use?
We use the intraoperative graft assessment for every graft in every case. And this is not because I don't know how to do coronary surgery or I'm new at it. I've done something on the order of 7,000 or 8,000 coronary bypass operations in my career, probably 20,000 distal anastomoses. We do it nonetheless to test because we know that it matters to the patient to have a perfect graft every time. And even if this device only detects a problem in low single-digit percentage of cases, if you can fix that problem for one patient in 100, then it's worth doing it for every one of those 100 patients. I do all my cases, or the vast majority of my cases, with a no aortic touch, all arterial technique, which is technically very demanding and has numerous pitfalls. We are aware of that. We're not blind to that fact. We're sometimes painfully aware of that. And one of the things that we do is to measure the flow in each graft immediately upon completing that graft before going on to the next one, so that we know we've achieved what we think we've achieved with each graft throughout the operation. And that's actually a nice way of thinking about how persistent ischemia is behaving in that heart in an off-pump scenario. We deal with chronic total occlusions and less tight native coronary stenoses, and we have to think about the sequence of grafts. Which one are we doing first? Which ones are we doing second? We think about the construction of arterial composite conduits so that there may be multiple outflows from a single arterial inflow. And so we want to do one before the other, and we want to measure and know that we have achieved adequate flow before we go on to the next one. So I find these flow probes very, very helpful and use them for literally every single case.
And how often, if a graft is going to fail, how often is it going to fail at that time with the probe intraoperatively?
To answer that question, I would say that the flow in the graft will be poor if there's a problem with the conduit, if there's a dissected arterial conduit, or if we have anastomosis in the wrong place on the coronary artery, or if we've hit the back wall with a stitch. Sometimes we redo an anastomosis and we can't really see why it wasn't right, but once it's redone, the flow is triple what it was. And that's just the way it is sometimes. Not frequently, but enough that it's worth doing.
Great. So I always like to, whenever I talk about different techniques, I like to talk about, where it's heading and what are the new techniques. And we've spoken quite a lot about that because I think things such as the devices and the epi-aortic ultrasound, they're a more recent development with our proximal anastomosis. So one of the sort of evolving trends would be, rather than having to perform a proximal anastomosis and touch the aorta, would be things like total arterial revascularization instead, which is completely avoiding that proximal anastomosis, such as an anaortic techniques as well, to minimize that manipulation of the aorta to prevent that risk. And the other thing is looking at patency data and trying to investigate this. But again, this is difficult because intraoperatively we can assess flow, but postoperatively it's going to involve invasive methods to assess the patency of our grafts. So that's why I think we don't have as much data on it. So what would you say is the future of the proximal anastomosis?
Well, just a comment on what you just said about the assessment of postoperative graft patency. You're quite right. Historically, that has required invasive coronary angiography, which is infrequently done outside the context of a clinical trial. The Japanese do it routinely prior to hospital discharge. And this has been a historic norm within that country and has provided the opportunity for remarkably high quality patency follow-up, at least prior to hospital discharge, for many thousands of patients in Japan. So the data exists there for short-term outcomes. There is one paper by Italian group, Lala was the first author, that documented a correlation between longer-term adverse cardiac events and intraoperative graft patency measures and flow measures. And the particular take-home message from that paper is that if the LAD has a flow greater than 15 versus less than 15 mLs per minute, that is a break point in the likelihood of a major adverse cardiac event in 3 years of follow-up. As one would think, it makes sense intuitively to believe that grafts with good flow will lead to better cardiac outcomes than grafts with poor flow. And there are a few papers that would support that belief. I think the future is going to be non-invasive measures of coronary graft patency. The latest generation of coronary CT scanners is remarkable. Next generations will be even better. The single photon counting scanners from Siemens and soon to be from other competing organizations or corporations are a game changer. They will make higher resolution images than invasive coronary angiography. And again, as I said at the very beginning, we talked about how old the concept and techniques for proximal anastomoses are. Well, the diagnostic coronary angiogram is even older. And new technology, both hardware and software, will soon make diagnostic coronary angiography obsolete. And we will have much better longer-term graft patency data based on non-invasive imaging technologies.
I think that's a really exciting sort of point to end on, is that, it is still something that is evolving. When people talk about, cardiac surgery as a dying specialty, multiple times on this podcast, I end it talking about the future and how exciting it is that actually we're still at the beginning, really. We're still learning, we're still developing techniques and doing the best we can for our patients. Graft patency is something that all surgeons have probably always wanted to know. Find me a surgeon that doesn't want to know what their graft patency rates are. And so with these new techniques, it's going to be really interesting because then people will just want to do better.
I think feedback is really important to self-improvement. And as you pointed out, we've been operating largely in a black box. As long as the mammary graft is patent, at hospital discharge, most patients will do very well clinically. And absent imaging of the grafts, most surgeons conclude that all of their grafts are patent all of the time. That is unlikely to be the case. I think as we have wider dissemination of better non-invasive imaging, we're going to have a lot more information to drive intelligent evolution of surgical coronary revascularization.
And stop the Schrodinger's graft, where it's patent until you look at it and it's not patent. So my key take-home messages from this fantastic episode, thank you so much, would be plan your grafts well, plan your proximal anastomosis well, respecting the anatomy of the heart, especially the left ventricular outflow tract, respect the aorta and the consequences of negligence at that part, and pick a way that you want to do and learn it well and do it well and always focus on that. Any other sort of take-home messages about proximal anastomosis that you think trainees need to remember?
I think it's important to remember that it's important. The blood has to flow through both anastomoses to get to the myocardium. Proximal anastomosis is equivalently important to the distal anastomosis. It may or may not be easier to do, but it is every bit as important.
Great. And I think if people want to go away and learn a bit more about it, there's the 10 Commandments papers, really worth a read. CTSNet have some step-by-step proximal anastomosis videos that are short videos made by our viewers. And there's actually a really nice video on epiaortic scanning that is, again, a short video just to understand what's going on. And so thank you so much for being on the podcast, Dr. Puskas. It's been a pleasure.
It's great to have been here. I hope that everyone enjoyed it and finds it beneficial.
Great. And before you go, there's one question I like to ask all my guests. If you could go back to yourself at the beginning of your cardiac surgery training, your cardiothoracic training, and give yourself one bit of advice, just in general about training to become a cardiac surgeon, what would it be?
Maybe to have kept my little black book longer. I used to keep a little leather-bound book in the left front pocket of my white coat, and I would write down 3 things that I learned each day. And I would read the book from the front to the most recent page every weekend. I think if every surgeon kept that book for the first 20 years of their career, instead of just through the residency, world's patients would have better surgical care.
I think that's a really nice thing to end on and something practical that our trainees can take away and start from today. So thank you so much. It's been an absolute pleasure. And thank you everyone for listening in to this month's episode of the Atrium. Stay tuned for next month's episode.
Bye now.